Hi, I'm Seth Taylor, an athletic trainer at Bethany College, and this is my research proposal into injury and the grieving process in NCAA Division III athletics. In the competitive collegiate sports environment, injuries can often take athletes out of competition or affect their day-to-day lives. It has been reported that nearly 1 in 6 athletes in the United States have sustained an athletic injury severe enough to keep them out of activity. With such a great number of athletes facing injuries serious enough to warrant removal from competition, it is important to understand how the athletes respond to these events from a psychological perspective. How does an injury affect an athlete's self-perception? Do athletes undergo feelings of grief and loss when injured? Are these feelings affected by how strongly an athlete's identity is tied to their sport or their athleticism? Does the nature of the injury affect these feelings? With this proposal, we hope to explore the impact of acute injury, chronic injury, and/or injuries that require surgery, and what effect they have on an athlete from a psychological perspective. A quick review of the terminology we'll be using. An athletic trainer is a healthcare professional who collaborates with physicians to provide preventative services, emergency care, clinical diagnosis, therapeutic intervention, and rehabilitation of injuries and medical condition. A physiotherapist is an analogous profession in countries outside the United States. A clinician is a healthcare professional responsible for the direct care of a patient. Athletic trainers fall into this category. A patient is anyone receiving care, treatment, or diagnosis. In this case, collegiate athletes. Let's first talk about the Kubler-Ross model of death and dying. The Kubler-Ross model states that terminally ill patients normally go through 5 stages of grief: denial, anger, bargaining, depression, and acceptance. Denial is the first stage, in which the patient denies that the event is even happening to them. Anger is the next stage in the progression, in which the patient lashes out with hostility toward those around them or place blame on someone or something else. Bargaining is the third stage. The patient begins to try to change their outcome by doing or changing something. Depression follows as the patient slumps into a deep sadness over realizing they cannot change their outcome. Acceptance is the final stage, wherein the patient understands and accepts what's happening to them. The Kubler-Ross model of grief also applies to non-death areas of grief, such as loss of a relationship, loss of a job, parents' divorce, and any situation that brings about great change to those experiencing it, both firsthand and those affected by the outcome. In regards to applying the Kubler-Ross model to a clinical setting, a 2003 data synthesis by Harris concluded that integrating a common stage theory, such as the Kubler-Ross stages of bereavement, is beneficial in providing athletic training students and athletic trainers additional skills to recognize and mediate negative psychological reactions to injury. By recognizing the stages of grief in the model, the clinician can plan their intervention to be better tailored to the patient's specific needs at the time, which will lead to a more positive patient experience and better patient outcome. Psychological factors are being increasingly recognized by sports medicine professionals as important during the rehabilitation process from sports injury. If a patient is undergoing the stages of grief, recognizing these stages may allow the clinician to design the appropriate intervention. In a study of injuries in professional dancers who use their athleticism for a living, it was shown that emotions immediately post-injury are negative and then progress to a more positive feelings with recovery. By offering a deeper understanding of what the patient is experiencing, the clinician can offer better intervention and counseling services. These factors are important to consider in the athletic training field because the ultimate goal is to return the patient-athlete to competition with minimal complications and without detriment. In addition to pain, significant increases in negative mood states after athletic injury have been well documented in a wide variety of populations. In a review by Schwab, Reese, Pitzinger, and Yang, their findings in the literature support the effectiveness of psychological intervention in reducing post-injury psychological consequences and improving psychological coping during rehabilitation. Psychological factors have been found to play important roles in the recovery from sports injury. Psychological interventions to facilitate sports injury rehabilitation have been developed, implemented, and evaluated. Injuries affect patients that most self-identify as an athlete, because much of their personality is tied to their ability to perform. The inability to be physical results in the death of themselves as an athlete, and the grieving process is much the same as losing a loved one. Some athletes' self-esteem and self-worth are often wrapped up in their bodies and their ability to perform with their bodies. By the same merit, an athlete who does not tie their persona as tightly to athletics as they do to their field of study or to their family, etc., will not experience the same level of grief as an athlete when experiencing an injury, because they already have a solid foundation by which they define themselves. Green and Weinberg stated about those who self-identify in that matter, if an individual is centered on the role of an athlete and then becomes injured, his or her identity might be threatened. In essence, because his or her life focus is primarily sport-related, the occurrence of injury may disrupt that focus and lead to emotional and psychological reactions, which are typically negative. It is also important not only that the clinician knows that this process is normal, but that the patient knows and understands that these are normal, lest they become more reclusive and withdrawn from their teammates and clinicians. Several researchers have reported that athletes experience greater psychological crisis than non-athletes, but are less likely to seek out professional counseling services. The clinician must take into account this mentality when dealing with these athletes, because the goal is to expedite the process of getting them back and to improve their quality of life. The impact of negative emotions on recovery of athletes, can be extreme. Patients may have feelings of fear which compound into negative emotions like anger and depression. The patients may erroneously fear loss of the support of their team, friends, or family, which can lead to detrimental behavior. In a qualitative study conducted by Johnston and Carroll, a particular case of a 21-year-old male athlete who was forced to retire from a sport after an injury highlights the depth and severity of these emotions. The most extreme response came from a male rugby player who was forced to retire at the age of 21 from all contact sport. Apathy appeared 1 month post-injury. The individual stopped attempting to attend university classes, fell behind in work, watched television all day, and spent the evenings drinking alcohol. Indeed, depression and drinking led this individual to contact a helpline for alcohol abuse. Recognizing and understanding what a patient is experiencing can offer insight into how the clinician can intervene and help. Johnston and Carroll also completed a study in 2000, which showed that athletes were more likely to show confusion, pessimism, fear of re-injury, loss of confidence in their abilities after injury than non-athletes. In a survey of 187 athletic trainers, 100% of them agreed that positive rapport between the clinician and the patient was of ultimate importance to a positive outcome for the patient. In a study in the New Zealand Journal of Physiotherapy, it was found that the majority of patients will not adhere to the therapy to at least some degree, and that confronting them about rehabilitative truancy can hurt the rapport. And 3/4 of the patients were more likely to adhere if they were educated about their condition or what they were going through or what they were feeling and understood that it was normal. Athletes feel less of a need to be challenged emotionally by their athletic trainers, and there's probably no good time to be confronted about one's values and attitudes. In a study by Fisher and Hoisington, nearly 90% of athletes that completed and returned surveys listed that good rapport with their athletic trainer was essential to rehabilitation adherence. It is important to those providing care and to the patient that they're able to empathize with each other during the healing process and to maintain a constant status of support to the injured athlete. After injury, the athlete may feel scared or unsure about their future, and they may feel isolated or feel like they lack support from their team or friends or family. So if the clinician can help maintain the positive feelings, the detriment to the athlete can be minimized. It's also important that the patient feel like they maintain some sort of semblance of autonomy during the rehabilitation. Without autonomy, a student never truly learns to endure struggle without being rescued. Injured athletes who are not autonomous will blame failed rehabilitation on those around them rather than their inability to adhere to the limitations and guidelines of the rehabilitation. Social support is an invaluable component of this autonomy. Factors that were needed were somebody showing concern, feeling like they were being listened to, an ability to reflect with others, and motivation to be disciplined in their own action. Psychological skills have been shown to benefit injured athletes by promoting and maintaining a positive mindset. With so many athletes projected to suffer injury, it is important for clinicians to handle patient rehabilitation and recovery, and to look at both physical and psychological aspects of the injury. The relationship between psychology and injury has been documented and utilized in the field of athletic training, but relatively few studies have been conducted in this domain, especially in the lower divisions of NCAA collegiate sports. More research needs to be conducted into the psychology of injury in the NCAA Division III collegiate setting, due to the unique nature of Division III sports not offering athletic scholarships, as well as being the largest NCAA division in terms of institutions. This means loss of athletic ability does not lead to loss of scholarships, and therefore the emotional toll and feelings of loss may differ from other athlete experiences, like at the elite level or Divisions 1 or 2. With so many athletes in this setting, it's critical that the clinician have a deeper understanding of the psychological machinations of their patients. For the design of the study, athletes who have personally experienced an injury that removed them from competition or activity for different lengths of time will be interviewed in depth about their perceptions and experiences before, during, and after the incident, as well as before, during, and after rehabilitation. The population I will be selecting from is the athletic population from Bethany College. Bethany College is the home of 22 intercollegiate teams, which is the most in the state of West Virginia. Bethany College is home to a very diverse group of athletes from different backgrounds, different states, and even different countries. For the sample, athletes who have personally experienced an injury that removed them from competition or activity for different lengths of time, less than a month, 1 to 6 months, 6 to 12 months, over a year, or even indefinitely. And for the sampling procedure, it will be purely on a volunteer basis. The interviews will be recorded as audio files and then will be transcribed onto a text document, and the original audio file will be destroyed. For the guiding questions I will use: what sport did you play? When were you injured? How long were you removed from competition? Do you feel as if you self-identify as an athlete? How strongly? How did you feel before you were injured? How did you feel upon onset of injury? For about how long did you feel this? How did you feel after the injury? How was your experience with rehabilitation and or surgery? And of course, I will be asking guiding questions along the way to extract more specific data from them. For the delimitations of the study, Bethany has a diverse and relatively large athletic population, with more than 300 active athletes, meaning it means that it's more than likely that about 50 of those have been injured to the point of being removed from competition. And surveying such a small population quantitatively may not reveal any statistically significant findings. But in a qualitative interview, assuming that 10 to 20% participation in the interview process, about 5 to 10 interviews could be conducted, which could give wide varieties of views and opinions from athletes in the division. Some possible outcomes are a deeper understanding of patient experience by the clinicians that handle them, and this could lead to better patient care. It could also lead to a deeper understanding of the large population of Division III athletes that will utilize athletic training services. It may also possibly show a trend at the Division III level that may differ from the current literature. Thank you for your time. In conclusion, the current literature points toward feelings of grief, loss, and negative emotions in athletes after injury. This study could give insight into an underrepresented population in the literature in collegiate athletics. And understanding how this sample experiences the stages of grief after injury could offer many clinicians insight into their practices and perceptions in the Division III clinical setting. Thank you for watching. I hope you'll consider my proposal, and here are my sources.